Perfect. So first of all, I'd like to welcome everybody on behalf of the Canadian Breast Cancer Network to this webinar, Combating the Effects of Cancer-Related Brain Fog. And welcome Dr. Heather Palmer. Thank you for joining us this evening. We're really excited to have you back. We had the opportunity to work with Dr. Palmer for the National Conference for Young Women Living with Breast Cancer that was hosted in 2010 in Toronto. And she spoke about the same topic, and very well received and a lot of really great feedback from that workshop. So we're really excited to have you back. So thank you for making the time to do this. I just want to go over a couple technical details before we begin. As far as questions go, Dr. Palmer will be taking questions at the end of the presentation. So the presentation is about 45 minutes, and then we'll have half an hour for questions at the end of the presentation. What we'd like you to do is we will unmute all the lines, which are muted now, at the end of the presentation, and you'll be able to actually ask the questions verbally. The presentation is being recorded, so if you do want to say who you are, we'd suggest that you just use your first name, because this will be put up and hosted on the CBCN website starting next week for those of us who couldn't join today. So just to keep it a little bit more confidential, please just use your first name. And in order to ask a question, there is, as I mentioned before, a chat function at the top left-hand side of your screen. And if you have a question to ask, you can simply type in to that chat box question, and that way I can moderate who's going to be asking the next question, and then I'll simply call you on your name, and you can ask the question to Dr. Palmer then. So on that note, I'd like to turn it over to you, Dr. Palmer, and let you begin this presentation.
Great. Thanks, Jen. This is fairly new for me. I've never given a webinar in this format, so I hope it goes well, and I hope we do get lots of questions at the end in the event that there's some areas that I didn't actually address. What I'm going to do is I'm actually just going to start off by giving you a little overview of what we plan to talk about today, and the reason for that is because we have a very short time period in order to cover a fairly large amount of information. So first I just want to go over a little bit of the terminology and identify some of the common symptoms that have been identified through the research and explore the potential causes for cancer-related brain fog. Then I'm just going to very briefly discuss the importance of neuroplasticity and its role in cognitive rehabilitation, because it really sets the tone for the rehabilitation program that I will then present, which is an evidence-based cognitive rehabilitation program that's been designed specifically to help improve the cognitive capacity for people with cancer-related brain fog. And through talking about that particular program, as I go through the different areas of our program, I'm hoping that people will start to learn some tools and strategies so they can start maximizing their cognitive capacity right away. And at the very end, I'll have an opportunity, hopefully if time allows, just to really highlight some of our experiences having had several hundred people go through our program. We seem to see the same sort of pitfalls in each of the same sections in terms of where participants are having great difficulty to really incorporate the information. So I'll share some of that information as well. So just to start with, we'll go over what is cancer-related brain fog. And as you'll see on your screen, it's also called chemobrain or chemo fog. In fact, those are much more common terms. And those are terms that are originally coined by the patients themselves. And they've been terms that have been around for many decades, and they continue to be used. Even in an article I read today, they kept referring to chemobrain, even though within that same article they recognize right off the bat that we aren't convinced that it's necessarily the chemotherapy or that chemotherapy is the only cause. So we try to make a big effort to actually call it cancer-related brain fog, and the three reasons for that are on the screen in front of you. First of all, we don't know for certain that chemotherapy is the only cause, and we'll talk about some of the other potential causes in a minute. I think it's also really important to be very careful about alienating people who have had cancer or have cancer and have the same constellation of symptoms, but they never actually had chemotherapy or they haven't yet received chemotherapy. So I think traditionally what has happened is people have gone to their healthcare professionals and they've talked about these cognitive changes, and they felt somewhat alienated over the past several decades because it's not really addressed by any given healthcare professional, and it doesn't really fall under the umbrella of a single healthcare professional, so it's not really occupational therapy or oncology or even psychology or social works roles. It's covered a little bit by each discipline, but not a whole lot by any one discipline. So what's happened is people haven't really had anywhere to go, or they didn't really know how to address it. And I think cancer survivors have felt that the condition has not been really widely accepted, and there has been no support for it. So there's great concern on our part. If we call it chemo brain, then we will continue to alienate all those people who have never had chemotherapy, who have the exact same set of symptoms. And then finally, I think it's really important to recognize that there are many other forms of brain fog. So cancer-related brain fog is just one form. There's also aging-related brain fog. Young mothers shortly after giving birth in the early years, they can experience brain fog. There's brain fog associated with depression. There's brain fog associated with brain injury. There's even brain fog associated with stress and lack of balance in the workplace. So another reason for calling it cancer-related brain fog is to distinguish it from the other forms of brain fog. So what are the common symptoms? Well, most often people will talk about changes in memory, and they tend to use memory as a somewhat umbrella term to describe a whole variety of functions that through the program we learn to discover actually the difficulties are falling in a different domain. It's not just the memory domain itself. But when you combine changes in memory with difficulties with verbal skills, the kinds of complaints and concerns people seem to express include word-finding difficulties, so great difficulty retrieving a word that they want to retrieve, or making a mistake and coming up with the wrong word or a word that doesn't actually exist. If we also look at verbal skills and memory in general, there's been lots of description of concerns regarding writing, so having trouble spelling a word, even simple words, or looking at it and knowing that it's not spelt right but not being able to figure out how to fix it. Or if we expand just spelling into writing in general, quite often people notice difficulties in terms of emails. So they will send emails to friends, and when the email comes back, there might be big chunks of what they thought they had written no longer there. They had not written them. They thought it. So there's the general gist is there, but sentences are missing. And then also reading would fall under memory and verbal skill changes in terms of there seems to be a fair amount of surprise and disappointment with difficulty with reading. And the reason for the difficulty with reading, it's not completely clear. Part of it probably relates to changes in attention and concentration and the extreme fatigue that people can feel. So it's difficult to actually process the information that one is reading. So, for example, when they put their book down and go and pick it up the next day or a few days later, there's a greater tendency now to have to reread several pages. In terms of just short articles, quite often people find that somewhere along the way they missed an important point. So when they end up getting to the end of the article, they don't really get the whole gist of the article because a very important point was missed, and they find they have to reread portions of the article to make it make sense. And I think that those kinds of difficulties, the word finding, the reading, and the writing, are particularly problematic and frustrating. If we talk about attention and concentration, I don't think it's terribly surprising that people's attention and concentration may be affected by some aspect of the cancer, whether it's from the diagnosis right through treatment to the recovery. The bottom line really with our thinking capacity is if you cannot get the information in and process it, then it's unreasonable to expect yourself to remember it later. And so any factors that will affect attention and concentration, whether it's fatigue or pain, some medicines, an inability to hear or see the information, all of these factors are going to compromise one's ability to actually process the information and get it in, which means when it's time to remember it later, it was never actually processed on a very deep level. So the ability to actually remember it is now compromised. I think where we tend to see the greatest number of difficulties and changes in individuals who have had cancer is in their executive functions, which is really referring to higher-level functioning skills that differentiate us from other animals. So skills such as doing mental calculations in our head, so calculating a tip in a restaurant, or being able to calculate forwards and backwards, so knowing what today's date is, trying to figure out what the date was last Wednesday. Strategic processing is also an executive function task, so the ability to process information in a strategic way so that it's encoded better so it's more accessible later. I think one of the biggest areas that people really tend to notice differences in is their ability to multitask, and then the domino effect of what failures in multitasking then results in. And I think the reason people have great difficulty with multitasking is because for some reason when our thinking capacity has been compromised, our mental pop-up seems to be compromised as well. And the mental pop-up is a function that allows information to pop into mind at certain points in time that are the appropriate points in time. So for no reason whatsoever, it will just pop into our mind, oh, it's time to refill my prescription, or, oh, it's time to go and pick up the children from school. So there's almost like an internal trigger where information is frequently popping into mind when we need it. And as a result of some aspect of the cancer, it would appear that the mental pop-up is malfunctioning. And that's having a very large impact on ability to multitask. And then when we see failures in multitasking, stress levels increase, frustration increases, and people are more prone to making memory mistakes. Those are the primary cognitive changes that people have described. But quite often people also notice some changes in their motor function and their coordination. And when you actually combine that with spatial skills or a change in spatial skills, and spatial skills is defined as knowing where your body is relative to the space around you. So what typically people start to notice is there's a greater tendency to bump into people. Or if they're walking through a doorway, there's a greater tendency to just catch the edge of the door jamb and lots of unidentified bruises on shoulders or on knees and the lower part of legs from bumping into tables. And the reason for that is there's some aspect that can be attributed to changes in spatial skills, so not recognizing as well the distance around the body, but that also coordinated with changes in motor function. So for many, when we're about to bump into somebody or something, there's a motor function to be able to quickly recover and save ourselves from hitting the object or the person. But there seems to be for some people, some aspect of the cancer has caused changes in both the spatial skills and the motor function's ability to rescue or recover from that. And then finally, psychological well-being is affected. So there are a whole host of psychological constructs that are likely going to be impacted, affecting the way an individual feels about themselves and their environment. And this, too, will have an impact, an eventual impact on cognition. So what causes these changes? Well, most of the research and most of the emphasis has been placed on looking at the chemotherapy, which is a very smart place to start. And there is some fairly good research that does identify that the chemotherapy is likely playing a role. A lot of the research up until now has been primarily done in breast cancer survivors. But there's also some very good animal research that's been done, specifically looking at the role that chemotherapy plays in terms of cognitive side effects. And I think that the research, especially the animal research, is getting to the point where there's a good likelihood that chemotherapy is playing a very large role, but there's also a good likelihood that it's not playing the only role, that there are some other factors that could be causing some of these cognitive changes. And one other place to look would be to look at the cancer itself. Why is it that there are many people who haven't yet had chemotherapy or never have chemotherapy have the same constellation of symptoms? And if that is the case, then these changes cannot just be caused by the chemotherapy. So is there possibly something about the cancer? And that's also a good place to look, because the autoimmune system, the body will automatically, when it detects a cancer, it will start to launch an attack. It will do its job to try and beat out or kill whatever the foreign object is that it's detecting. And part of that process, quite often result in an increase in the release of cytokines that pass the blood-brain barrier and can cause a little bit of inflammation. At the very least, there is an increase. So it's quite possible that it might not just be the chemotherapy that's causing these changes, but there may be something about the cancer itself. Another place to look would be the cancer-related treatments. It's very unlikely for people who are being treated for cancer to not also to be receiving some other form of treatment, whether they're naturopathic or homeopathic, or anti-nausea, anti-fatigue, anti-anxiety, or anti-depression medicines. So quite often with the diagnosis of cancer and the start of treatment, people actually start taking a whole host of other medications as well. And it's quite possible that there's something about that combination that's contributing to these changes. Without question, it would always be important to look at genetics. Is there a possibility that some people are just genetically predisposed to having cognitive impairment following cancer treatment and diagnosis? And there is a line of research that is looking at that, and they've identified a couple of genes or gene mutations that may be associated, in particular one that may be associated with Alzheimer's disease. Although the research is in its infancy, I think it's really important to recognize that there is a possibility that genetics might be playing a role, and this might help to explain why some people, they will meet somebody who has the same sort of cancer, the same treatment, and very different outcomes in terms of side effects. And it might come back to our genetic makeup that is causing the difference in side effects. And then finally, as I've mentioned, the psychosocial constructs. It's very possible that from the point of diagnosis on, the psychological well-being is going to be affected, and as a result of that, there's going to be changes in cognition. So again, it would be unrelated to the chemotherapy or any of the previous points. It's simply related to a change in psychological well-being. So what do we know? Well, we know that there's hundreds of thousands of people experiencing a variety of life-altering and frustrating cognitive symptoms that for the most part they did not expect or they were not forewarned were a possible side effect of their cancer or treatment. So it's not often that people are actually told this is a possibility, and quite often if they are told that cognitive changes are a possible side effect, they tend to be told at a point in time where that information isn't particularly important, so they aren't actually processing it. So there are bigger concerns at that point in time when they're being given that information. We also know that the symptoms usually appear at some point following diagnosis and or treatment, but they sometimes can even present themselves before the diagnosis. We know that the cognitive difficulties tend to improve over time, which is fantastic. People just start to naturally recover or develop their own compensatory mechanisms. But that time period can be quite variable, often lasting between 2 and 5 years, with a very small percentage of people who may continue to have difficulties past the 5-year mark. We don't yet know the cause, and we don't know of any pharmacological treatment for it, but the good news is that the condition is receiving increased attention from researchers and healthcare professionals, and we are starting to see more and better research that's being done to try and understand and treat it. So despite what we do know and the absence of pharmacological interventions, the good news is that the neuropsychological rehabilitation or neurorehabilitation can help, and that there are programs that are specifically designed to address it. However, before I review the cognitive rehabilitation program that we've been running for quite some time, what I'd like to do is provide a very brief overview of the brain and neuroplasticity, because it really does lay the foundation for the work we do, how we do it, why we do it, and the impact we believe that it has on improving the brain function. So on the slide in front of you, there's a picture of the brain, and on the right-hand side, there is a picture of a brain that is trying to identify the possibility or the potential for neuronal pathways or neuroplasticity. So research has gotten to the point where they are able to neuroanatomically map the brain with extreme precision. So they are able to pinpoint regions of the brain and actually stimulate a region of the brain to make somebody laugh or to make them cry or even remember a personal memory from their past. But for our purposes, it's not so important what the individual parts of the brain do, and it's not so important to strengthen the isolated areas of the brain. Rather, cognitive neurorehabilitation is about nurturing the connections between the brain regions and developing new connections if that's required. So one analogy that we often use is to describe these neuronal pathways is we describe them to be like a series of superhighways where neurons are moving back and forth along predetermined pathways or pre-established pathways at very rapid speeds. And for some reason, those particular highways now have potholes in them or they have roadblocks. So information isn't able to pass through that pathway as smoothly or as quickly or as efficiently as it used to. And cognitive rehabilitation is all about practicing old techniques to, in essence, repave those surfaces. So every time you practice a technique, it's like laying down another thin layer of pavement to try and smooth it out. And when necessary, sometimes people need to learn new techniques and new strategies, and that's similar to building a new highway or a bypass route to compensate for the area that's not functioning as well as it used to. So the picture on your right is a drawing trying to demonstrate the importance of these pathways, of which there are many of them within the brain. So the slide in front of you is an interesting slide because what it is it's a study that was done in a pair of twins, identical twins, monozygotic twins. And twin A was diagnosed and treated for cancer and expressed on a very regular basis that she was not thinking as well as she used to. Twin B did not have cancer and had noticed no changes in her cognitive status. Twin A went through, and Twin B, they went through a battery of neuropsychological measures. So they had tests of memory and word finding and planning and organization. And over the several days of doing the testing, for the most part, there were no real significant differences between Twin A and Twin B on the tests. So the measures basically were saying that Twin A is functioning just as well as Twin B. And I think that's the situation that many people encounter if they do go through and get some testing done, is quite often they are told that they are performing within normal ranges for their age and their education level, even though they themselves know that there's been a functional change of some sort. So Twin A and Twin B then had an opportunity to go into an fMRI scanner, which is an MRI, a magnetic resonance image scanner, with a functional component. And the functional component means while they are in the scanner, they have an opportunity to do a task. In this case, it was a memory task. And the researchers have an opportunity to look to see where is the blood flowing, how is it flowing throughout the brain while the person is actually engaging in the task. So it's a wonderful opportunity to compare different groups of individuals or different individuals. So in this case, it was comparing a twin who had had cancer and been treated for the cancer. How is her brain functioning while she does a memory task compared to her identical twin who has not had cancer? And even though on this particular memory task they did just as well as one another, so they reached just as far in terms of the difficulty levels, you can see by looking at the pictures that there's quite considerable differences. So twin A's scores go from left to right across the top, and twin B's go from left to right across the bottom. And the first column is the simplest version of the task, and then the task gets increasingly more difficult. So in the first column, in the simplest form of the task, twin A, it's as though her brain is really revving it up. She's saying, wow, this is tricky. I really need to activate my brain here. Whereas in that same simple form, twin B is practically at rest. There's very little brain activity. And then as the task gets more difficult, twin A manages to maintain her activity level no matter how difficult the task got. Twin B, however, she has to raise her activity level once it reaches the second stage of difficulty, and then she pretty much maintains that performance throughout. So even though they performed the same on the test, quite noticeably we can see that there are differences, that the brain is responding differently and is having to work a little bit harder in Twin A's case in order to get the task done. And I think there's two really important pieces of information that come from this study. Number one, I think this may help to explain some of the extreme fatigue that people often feel. If the brain needs to be that active to perform simple daily activities, then it's not surprising then at the end of a day, even if it wasn't a terribly busy day, that people might feel that mental fatigue and the physical fatigue that can go with mental fatigue. I think a second important finding that comes from this piece of research is that quite clearly we see that Twin A, not only is there more activity, but she's actually using somewhat stronger or more expansive networks. So for whatever reason, as a result of her cancer, her diagnosis, the treatment, some aspect of that experience, her brain had learned how to compensate and develop an abundance of networks in order to allow her to do the task as well as she used to. And I think that's a really important point to recognize that the brain does have the capacity to function at the levels that it used to. It just sometimes needs to work a little bit harder at it, or it needs to have developed new connections or use different pathways. So our particular goal is to maximize individual cognitive capacity. In other words, what we try to do is improve the way people think by improving the strategic processing aspect of memory. And we do this by teaching and practicing a variety of techniques and strategies while constantly promoting self-awareness and individual style so that the strategies can be integrated into daily life. And our program is evidence-based in that all of the strategies that we teach and practice in the seminars have come from science. They are picked to be the best ones that the science identified as being longest lasting and having the greatest impact on individuals. They're ecologically valid in that we put a very large emphasis on trying to make sure that the tasks and the strategies can be integrated into day-to-day life. It's cost-effective in that it's a group program, so we have up to 10 people who are being trained at the same time. And it's multi-purpose and a multi-dimensional program. So it's our belief that to truly maximize cognitive capacity, it takes a combination of memory skill training, effective task management, and psychological well-being. What I'm going to do is I'm just going to go through each of those three components and tell you a little bit about what we do and why we do it. And in the process of doing that, hopefully there'll be an opportunity for individuals to start learning or practicing a few techniques on their own. So in terms of the memory component, the goal of our memory section is to teach individuals how to encode information in deeper and more meaningful ways. Young brains seem to be much better able to just suck up information. Whereas as our brain gets older, or if we've experienced any changes for whatever reason, the brain doesn't seem to be as successful at doing that just naturally. It takes more effort to suck up that same amount of information. So it's as if when we get older, information just bobs up and down on the surface of our brain, and if we don't actually do anything with it, then a wind will come away and just blow it away, which is why there's that sensation of not remembering. I like to use the analogy of the sponge. So if we think of a young brain as being like a fresh new sponge that just sucks up everything, then an older brain or a brain that's been compromised for any reason is a little bit more akin to a crusty old sponge. And the point I'm trying to make is that crusty old sponge can still successfully clean up a mess, a liquid mess on a counter. It just takes a little bit more time and a little bit more effort. So with a little bit more time and effort, we believe that brains that have been compromised a little bit or that are aging can still function just as well as younger brains. And this whole concept of processing on a deeper level is generally most easily explained by the graph that's in front of you, which is a very simplistic research project that really seems to highlight the concept of different levels of processing. So in this particular study, there were 3 groups. They were all given the exact same memory task, and they needed to recall the words at a later point in time and then recognize the words from an array of many words. The only difference between the 3 groups was a slight change in the instructions they were given. The first group was told that they were going to be given a series of words that they needed to remember, but they were encouraged, when you see the word, we want you to focus on the first letter of each word. So, for example, ball starts with B, or cat starts with C. The second group was given the same words and the same instruction, except the slight variation was they were told, when I show you the words, I want you to try and come up with a rhyme for the word. So in order to come up with the rhyme, you actually need to think a little bit more deeply about the word. So, for example, ball rhymes with hall, cat rhymes with mat. And then the third group was given the same words, same instructions, with the slight change being, when I read the word to you, I want you to come up with a sentence. I want you to use the word in a sentence. So all of a sudden you can see it actually takes a lot more effort to come up with a sentence. You now have to think about the word and its meaning and put it in the context of a sentence and somewhere dig up your old grammatical rules of how to make a proper sentence. So, for example, my son likes to play with a ball, or I don't have a pet cat. And later, when there's an opportunity to look at their ability to recognize the words, you can see the significant differences. People who processed on a very surface level, so they just focused on the first letter of the word, remembered less than 20% of the words. Those who focused on a deeper level, such as using a sentence, were up at around 80% accuracy. So this is what we're trying to get at with the memory section, is to really emphasize for people, how do you get that information in a deeper and more meaningful way, and what sort of effort you need to put in to do so. So how do we actually process information more deeply, and what are the tools or the strategies that we teach to try and encourage that? Well, we focus on 2 main areas. We focus on external strategies and internal strategies. We promote the external strategies. Whenever possible, it's important to use the external strategies. They tend to be much more sophisticated and much better exercise for the brain, but they also tend to result in much greater success. There's fewer mistakes if someone's used an external strategy. So external strategies really are referring to those strategies that are outside our body, such as lists or notes or calendars. The program leaders and myself are big fans of little personal timers that you can pick up at most dollar stores. They can clip on you or go on your refrigerator, and they give an opportunity to set a timer. So if you have about a half an hour before you need to go somewhere, you can set the timer for 30 minutes, and during that 30-minute period, you can actually become absorbed in a task. You can concentrate on a single task without fretting and worrying about missing the time to leave. Or quite often we find that time calibration seems to be a little bit off for people who have noticed changes in their thinking capacity. So there's a great tendency to get easily distracted. So, for example, you might start to send a couple of emails, and before you know it, you've spent several hours at the computer. So a timer is an opportunity to try and recalibrate that sense of time and say, I'm just doing a couple of emails, so I'll set my timer for about 15 minutes and see how I do. We talk a lot about the importance of routines and habits because people do have a very large number of routines and habits, most often that they're not even aware of. And what we try to encourage people to do is to recognize what the routines and habits are and recognize the areas where they're making mistakes or having difficulty and then map one onto another. So in a very simplistic example, if there's a tendency to forget medications, your morning medicine, but historically you have always had a cup of coffee in the morning and you do that almost without fail, then why not keep your medicines or your morning medicines with your coffee cup so that there's no possibility to break from that routine so you don't forget the medicines. And then finally, in the external strategies, we also talk a little bit about external self-talk, so the process of actually talking out loud. And this is an example of just a very simple strategy that we spend a little time teaching people that can have an immediate benefit. So talking out loud is where you actually make clear verbalizations, such as, I'm going upstairs to get my glasses. And quite often, most people will get to the top of the stairs and they will suddenly forget what it was they went up there for, or they got distracted on the way. By having said it out loud, you're much less likely to forget what you went up there for, or if you do have that fleeting moment of forgetting, you're more likely to remember it right away without having to travel back downstairs to some sort of trigger. And the reason this is just an example of why some of these strategies work. So the reason external self-talk is so successful is because by talking out loud, it forces the brain, it forces you to go slower. Most people cannot speak nearly as fast as they can think. So by talking out loud, you're actually forcing yourself to go at a brain processing speed that your body is more comfortable with. As well, when we think, we can think lots of different things at once. But when we talk, there's a greater tendency to only say one point at a time. So by talking out loud, you automatically impose an organizational process on yourself. And then, of course, when you talk out loud, you process it twice because you think it as well as hear it. So those are just some examples of some of the external strategies that we promote. And then what we do is we spend a couple of weeks practicing internal strategies. So we take the opportunity to teach a particular strategy, practice it. We do several little tests and tasks related to it, and then the participants have an opportunity to try it in a real-world context, and then we ask them to wipe their mind clear of that one, and we try another one. So we systematically go through the 6 internal strategies that you see in front of you to teach people how to use it and to get a good sense for themselves if it works or not. And ultimately, with the memory section, our goal is to find the combination of strategies that works best for individuals, combining a variety of external strategies with internal strategies and figuring out what systems might work best under a variety of conditions. However, having run the program with several hundred people, we do find some difficulties in terms of the memory training. We find that there is a huge resistance for people to try new ways and new techniques. Most people come to our program hoping that we're going to give them tools and strategies that will allow them to function at the levels that they functioned at before while doing it the same way. And that is not our promise. We do our best to try and get people back to their previous levels of function, but recognizing that it's most likely going to involve learning new ways and accommodating and modifying old ways. Another great difficulty people tend to have is with the concept of front-end loading. So the importance of really putting the effort in at the encoding stage. It's very obvious to participants when we're in the program that when they put the effort in and they try it out in the seminar, they see the immediate improvement and they see how much better they remember that information for a longer time period. But it does take time and it takes work, and what sometimes happens is when people get back into their day-to-day lives that are busy and chaotic, there's some sort of resistance to actually putting that effort and that time into it. And part of that front-end loading can be much less work if people practice a lot. So if you practice your techniques, even when you don't need them, then they're more likely available to you when you do need them. And then finally, people do have a tendency to fall off the wagon. So for several months after the program, people will continue to use the strategies, and if we remind them of them through one of our top-up sessions, they will continue to use the strategies. But over time, there's a tendency for people to go back to their previous strategies unless there's been some sort of constant reminder or the new strategy has now taken over the old way that they used to do things. Task management is the second section of our course, and it's designed to primarily help reduce people's feelings of overwhelm by helping them to better manage both their small and large daily tasks. So there seems to be quite an increase in people with cancer-related brain fog having difficulties with day-to-day activities, especially the larger, more complex ones, and starting to feel really overwhelmed and not being able to manage them at all. So the way task management works is it's a 4-step process that is designed to promote a present-minded state as opposed to the absent-minded one. So quite often, people spend a good portion of their day wandering somewhat aimlessly from one activity to the next, or where they go to do something and something catches their eye, so they do that instead, and something else catches their eye, so they continue on, and they continue on through their day in this way. That's what we would describe as being an absent-minded state. Task management, on the other hand, is designed to really promote present-mindedness, where one is always consciously aware of what they're doing and why they are doing it. And when somebody is present-minded, they're much less likely to get distracted or allow an interference. Or if they are distracted or there is some sort of interference, a present-minded person is much more able to get back on task and not continue down the path of interference and distraction. So the 4 steps that we teach are stop, clarify, simplify, and monitor. And they're very simple. The stop is simply a stopping mechanism that is designed to alert you to stop and take a deep breath and clear your mind of the clutter. One way to encourage the stopping mechanism is we really encourage people to use a catchphrase, some type of term, and most people already have a catchphrase, in fact, which is a little term or phrase that they tend to say more often than anything else. So hold on a sec, or relax, or breathe. And for people who already have a catchphrase, or as you're developing a catchphrase, what's happening is that will act as your stopping mechanism. And you use that catchphrase, and then you immediately take the deep breath and wipe your mind clear of the clutter. It's like wiping a blackboard clean. And once you've done that, you move into the clarify stage, which is the process of asking oneself 2 or 3 questions, 1, 2, or 3 questions, such as where am I going, what am I doing? And then the process of answering those questions requires simplifying, breaking tasks down, or breaking that answer down into a series of steps so it's manageable and not overwhelming. And then the 4th step is to monitor, to constantly check in that you are actually doing the tasks that you intended to do. Now, some of the pitfalls we find in task management training is a lot of people are misguided and think that they only need to run through the 4 steps a couple of times a day. But what we really encourage people to do is to, at a bare minimum, stop and clarify at any physical or mental transition. So, for example, when you get up to leave, one would stop and clarify and say, where am I going? What did I bring with me? And then if on the way out somebody speaks to you when you're done talking to them, it's another opportunity to stop and clarify. Before getting into the car, stop and clarify. Before getting out of the car, stop and clarify. So every opportunity to physically or mentally transition from an activity is an opportunity to at least stop and clarify. And if the clarify question requires simplifying, then going through the simplify step. It actually sounds much more exhausting than it is. To use task management many hundred times throughout the day is not exhausting, and it's not terribly time-consuming, but what it does is it puts you in a constant present-minded state, so you're always aware of what you're doing and why. Another pitfall is people often will say that they didn't use task management when they were in a hurry. So for us, we try to emphasize that as soon as you feel that you don't have time to stop and clarify, that's a sure bet that you should be stopping and clarifying. That's the time when you really need to do it. And then the other major pitfall is people tend to do stop and clarify, but they don't take the time to actually simplify it. So even tasks that don't feel like they require the simplify step usually are worthy of going through those steps, because you'll do it in a much more clear-minded way and you're less likely to skip a step or to forget something. And then finally, we have psychological well-being, which refers to how an individual feels about themselves, others, and their environment. And it can include a whole host of constructs, but the constructs that are on the screen really are identifying the constructs that has been shown through science to have the most direct impact on cognition. So generally speaking, when people are feeling better, they think better. And when they're not feeling so great about themselves or their environment, their thinking capacity is compromised. And there's some very nice research, especially in the seniors literature, that shows quite clearly the relationship, the very strong correlation between how people feel about themselves and how they're actually thinking, and how they tend to go up and down together. The way we focus on psychological well-being is we talk a little bit about the self-fulfilling prophecy and the need to really reverse this trend. So the need to actually get out of that negative spiraling cycle where there's a tendency to feel a complete loss of control over, to attribute small memory changes or certain difficulties to feeling completely out of control over all aspects of their lives. And when people feel that they don't have control over their lives, they feel that they can't do things, so they tend to reduce their activities and independence. And in the absence of cancer support centers, quite often what happens is cancer groups tend to become a little bit more isolated. They don't participate in their regular activities as much, often due to fatigue and other factors, but also related to the fact that they're concerned about their cognitive status. There's a concern that they might say the wrong thing or that they're missing the point of a conversation and they might embarrass themselves. So there's a real reduction in activities and independence. And that can really start to lead to avoiding both mental and physical challenges. So instead of seeing the activities as challenges, there's a greater tendency to see them as threats and use terminology such as, I can't do that, or that won't work, which can lead to a very pessimistic outlook on life, which can lead to depression, anxiety, and what we do know about those is that those are directly related to increased cognitive concerns. So on the other hand, what we try to do is to really promote the positive approach, to try and encourage people to reverse the trend, and then we embark on an activity that we hope reverses the trend for people. So the concept of I have control over my life. I may not have control over all aspects of my life, but I do have control, especially over my cognitive life, because there's techniques and strategies that I can learn and use to improve my thinking. And because of that, I feel like I can be independent. I don't have to rely on other people. Not to suggest for a moment that there's anything wrong with relying on other people. In fact, that's a very smart decision in many circumstances. But there's a greater tendency to see things in a more challenging frame of mind. So when something is complex or new, there's a greater tendency to say, how can I make this work? Or what is the solution here? Which is a much more optimistic and positive outlook and gives people the sense that they can tackle just about everything. So how do we actually do this? Talking about reversing the trend always makes sense to people, but the actual activity of making that switch can be much more difficult. And we spend a couple of weeks on this where we encourage people to prepare a to-do list of long-standing goals, the kinds of tasks that have been hanging over them for quite some time. And for the most part, program leaders will do this as well when their group is doing it. So there's that feeling of actually getting something accomplished that has been put off for a while. So they can be little tasks or big tasks, but they're the kinds of things that, for whatever reason, keep nagging at you and you don't get them done. Then with the support of the group, individuals are encouraged to pick one, and then together we help them to identify what the hurdles have been and help them break it down into a series of very simple and manageable steps that they can then work through within a reasonable time frame. And then we encourage them to come back the following week to talk about the difficulties they may have had, the accomplishments they had along the way, and if they've completed their task, to get ready to tackle the next challenge. And this is where we really start to see a big change in people. We see changes throughout the program, but at this point in time, this is where people come into the seminar and you can see a whole change in the look on their face. They look like they're in control of their life and they're feeling a lot more accomplished, and they feel like they're now tackling things that may have been completely out of control even prior to their cancer diagnosis. So some of the pitfalls we find in the psychological well-being section is when the task hasn't been selected particularly well. So if it's a task that is heavily dependent on somebody else and the other person is not available, or if it's a task that's just unreasonable given the circumstances with respect to either time or finances or space. Another challenge we find is sometimes people encounter unexpected events. So they've scheduled their task and they have a great plan for how they're going to work on their task, but then they have an out-of-town visitor come that they didn't expect. So part of it is about teaching people how to actually still make progress towards their goal, even though it might not be the same amount of progress they anticipated, and how to manage those unexpected events rather than to give up completely. We find that people who don't physically write down the steps that they're going to embark upon have less success. And if they don't break the steps down into manageable components, so they're too big, like do taxes, as opposed to breaking down the components to actually doing your taxes, there's much less success. We encourage people to start right away, immediately after the program has finished for that day, within that first day. So if it means writing a list or opening up a computer program or moving a box around, at least starting some aspect of the task immediately. And then the other problem is quite often when people successfully complete their task and they come in floating into the final seminar, thrilled with their success, they don't then ride the high and start their next task. They wait until they've settled down, and then they have to get their motivation up again to start the next task. So those are the common pitfalls that we see in that particular section. So just to quickly summarize, the symptoms do vary from person to person, but most commonly, the domains that are affected are memory and executive function skills. Chemotherapy is likely a cause, but not the only cause. And at this point in time, there do not seem to be any medications available that have been designed specifically to treat this condition. But the brain does have the capacity to grow and develop new connections between brain regions to compensate for areas of change. And specifically from the program itself, from the memory section, it's really important to always remember to try and encode information more deeply. If it's something important that you need to remember, then you need to put that extra effort in to remember it. And use the external strategies whenever possible. And throughout the course, we show plenty of examples as to where external strategies are actually better exercise for the brain than just the internal ones. But we'll always encounter situations where we don't have a pen and paper or an external strategy available, so it's really important to always keep your internal strategies tuned up and make sure to put the effort in. From the task management perspective, it's important to really think about that present-minded state where you're always consciously aware of what you're doing. And one way to help promote that is to stop and clarify, and then to reduce the feelings of overwhelm, to break tasks down into simple, manageable steps. And one of the best ways to improve the way you manage your day-to-day activities is to reduce multitasking. Do something to completion before starting the next task. And then finally, in the psychological well-being section, it's very important to remain positive and proactive, to set goals and to stick to them. And that's it. Thank you.
Thanks, Dr. Palmer. We're going to open the line up for questions in just a moment. So what I'll do is actually unmute everybody's line. But then if you're not going to be speaking and if it's not your turn to ask a question, I'm just going to ask you to actually individually mute your own line so we don't get any feedback. And you can do that by pressing *1, and then when I call your name and let you know that it's your turn to ask a question, then you can just hit *1 again to mute and unmute. And so in light of the topic of today's webinar, I'm actually going to type that into the chat here so that, because I've often put myself on mute and then forgot what I'm supposed to be pressing to unmute myself. So it's *1 to mute and *1 to unmute. So give me just one moment. I'm going to unmute all the lines, and then we'll open the floor to questions. If you do have a question, you can type in to all the participants. Just type question into the cursor field where you can enter into the chat. So if you just type in question, and then when it's your turn, I'll just call you by your first name and the first letter of your last name.
Participant lines unmuted.
So I'm going to ask Rochelle. You had a question. So, Rochelle, if you want to go ahead and ask your question to Dr. Palmer.
Hi, Dr. Palmer. Found it very interesting. When you talked about chemo or cancer-related brain fog taking 2 to 5 years for recovery. Is that from the end of treatment or from diagnosis of cancer?
That particular number actually came from a meta-analysis that was done in Australia, and a meta-analysis is designed to really take all the research that's been done on a given topic and try to identify what common trends might be, irrespective of where the research was done or what language it was done in. So it's really a general result that came out. And so that particular general result suggested that from the point of diagnosis, but it's quite variable, people who do have cognitive difficulties, they will start to gradually get better immediately once the treatment is done, and some people may continue to have difficulties until the 2-year time period, at which point most people are back to previous levels of function, but some will continue to have difficulties that gradually get better and better.
Okay, great. Thank you.
I can't talk to you right now, Lee. I'll call you back later.
Thank you. Just a reminder, if everyone could press *1 to mute your line, that would be great, and then *1 to unmute it. Peter, you had a question as well regarding timing. If you want to unmute your line.
Yes, Doctor. Thank you very much for your lecture. It really makes a big difference listening to you speak about some of the things I've been suffering from for 10 years now. And that was my question. It's been 10 years since I had cancer, and no sign that I'm going to ever come out of this brain fog. Or is there? I mean, will it eventually go away, or is this going to be with me now, do you think, forever?
It's a great question, Peter, and, you know, I am forever the optimist. I believe that even though it's been 10 years, with proper training and tools and strategies, I would like to believe that you would see improvements in your function and that you would be able to return to levels of function that are satisfying to you. It is tricky. The longer somebody has these difficulties for, it really starts to get to the point that it's hard to tease out just normal cognitive age-related changes and cancer-related changes. So typically speaking, the longer the difficulties have lasted, it's harder to start pinpointing and saying specifically it is the cancer or some aspect of the cancer treatment that is contributing to the difficulties that the person is having. Interestingly enough, though, from our perspective, why the person has the cognitive difficulties or what the cause is of little concern to us, because we always start right at the point of what are the areas of cognitive function that are most bothersome to you. Let's do what we can to try and fix those.
Right. Thank you very much.
I'm optimistic that with that kind of approach, there would be some tools and strategies within our bag of goodies that might help you to see some improvements.
Great. Thanks.
Thank you, Peter. Linda, please go ahead and ask your question.
Oh, hi. Yeah, I was just wondering, I know there's a few of us that have menopause. We don't have cancer, that we're suffering from this brain fog. Have you heard of that?
Oh, yes, I have. Was it Linda is your name?
Yes, yes.
Yes. Linda, you know, that's a great question. And at the very beginning when I identified why I call it cancer-related brain fog in order to differentiate it from other forms of brain fog, one area that I did not mention was perimenopausal or menopausal woman. But what I can tell you is in some of the private work that I do, my largest group of clientele tends to be professional women who have typically succeeded in their work and home life by virtue of internalizing and using internal mechanisms, so the mental pop-up and very efficient at multitasking and that sort of thing. And as a result of changes related to menopause, they start to discover that those internal brain functions aren't working the way they used to, so the mental pop-up's not working as well as it used to.
Yeah.
They are not successfully multitasking. And so they're having great difficulty because they've never really had to rely or haven't learned how to rely quite so heavily on external strategies. So they tend to bumble their way through it for a time period until they figure out what that balance is going to be that's going to work for them. On the other hand, I've seen lots of people who, for whatever reason, have had to learn these kinds of external strategies much earlier on in their life, either as a result of a learning disability or a pre-existing condition or a brain injury, and they tend to age or fare much better with age-related cognitive decline because they already have these external strategies and they're not quite so dependent on the internal mechanisms of their brain. So the short answer to your question is, yes, I do hear and see that often, and certainly this constellation of symptoms is not unique just to people who have had cancer.
So is this, like I'm listening to this for a few friends, and my sister, of course, she's in Vancouver. She couldn't, she's still at work, so she couldn't join us. So can I send her any of this? Is this going to be documented?
This is being recorded, this session, and it will actually be hosted on, if you go on cbcn.ca, it will be hosted on that site starting next week. So I can also send out a link to everyone who registered for this. I'll send out a link exactly the web page that you can find it on, and that way people can still listen to it through their computer and still get this information if they missed this presentation today.
Oh, great. Thank you.
You're very welcome. Thanks, Linda.
Okay.
Julie, you had a question for Dr. Palmer?
Hi, I just joined in the last 5 minutes. I was racing home from work as well, so I missed most of it, but I'm having a bit of trouble in my workplace. Okay, are you hearing me?
Yes, I hear you.
Sorry. I'm fairly young, and I'm 46, and had ovarian cancer and chemo about 3 years ago. And it's, I guess, physically on the outside I look quite normal. You know, I hate to use that word, but so a lot of my colleagues have a hard time understanding why I have to ask repetitious questions, or I get it one day and I'm not getting it the next day. So, I'm trying to get a limitation put on my work file, but again, it's very difficult to diagnose or measure.
Right.
So I'm having a hard time in my workplace, and I work at an airport, so I work in a stressful, not very predictable or scenario. So I'm always working in a place that is high stress.
Right. You know, Julie, in your comment, you've hit the nail on the head on so many issues. I mean, starting right from your comment about how you look as though you should be back to your previous levels of functioning, but you don't feel that way. And I think that's a frustration that many people with cancer have from within themselves. You know, they're told that they're better, they're actually feeling better, and so they expect to be functioning better, but also those around them, family members as well as workplace employees and colleagues. And I think that makes it particularly difficult. If I were able, I would make sure that this kind of information is presented to caregivers, workplace, etc., so that everybody knows that it's a possibility. But in the same hand, it's difficult because quite often people do re-enter the workforce and they don't want their colleagues to know that there's such a thing as cancer-related brain fog because they think that might be jeopardizing their ability for promotions. So I've had many people who have said they really don't want their employee to know about this because anytime they do make a mistake, they don't want everybody criticizing and saying, oh, that's related to their cancer, when in reality it was a mistake anybody may have made or that person had made several times beforehand. So it's a very sensitive subject, and what I always encourage people to do is to do their best to work with a vocational counselor if possible and to have some type of gradual return to work with the kind of open communication with the employer that is warranted given the relationship with the employer and your willingness to share that information. I'm not sure if that really helps, but it's certainly a difficult situation that you find yourself in.
That's right. Well, do I have just one more question?
Sure.
I guess I'm trying to go through the proper channels, and so I did ask my return to work counselor at the cancer agency, and they suggested I speak to my psychiatrist. My psychiatrist has suggested I go to my oncologist, who's retired, and I'm spinning my wheels, and it's almost easier to deal with, being labeled as lazy and stupid at work than it is to try and get this letter on my file.
Right.
But
I wonder if there's not an opportunity for you to present some of this information at your workplace. So gather some of the articles on the topic and summarize it in a way that it impacts you and your ability to do the job. So emphasizing all the positives, that you're still fully capable of doing your job and you're still very interested in doing the job, but sometimes it takes you a little bit longer, or you need to put a little bit more effort into it, and that certain circumstances certainly make it easier. So a quieter environment or an opportunity to take notes or whatever would be appropriate given the job that you have.
Yes, thank you.
Thanks, Julie. I should just mention before we continue, if you do have a question for Dr. Palmer that you're maybe not comfortable asking or want to speak more in depth about, then you can on the air here. Her contact information is actually up on the screen right now. And so if you did want to chat with her a little bit more one-on-one or have a question perhaps that you're not comfortable sharing with the group, please contact her directly. We will continue with the questions. Thanks, Julie. That was a good point that you brought up. And Bernice, you had a question for Dr. Palmer. It's *1 to unmute your line.
Hi. I just want to say how informative this session has been. It's the first time I've been involved in a webinar. Didn't know what to expect and totally amazed by it. My question was, can you explain the 3 p.m. brain block when you're at work? And I kind of think I figured it out because as I was listening to the other lady speak, I believe it's because my brain, because it's working so hard by 3 p.m., the fatigue starts to set in. Is that what I'm understanding?
It would be hard to identify specifically why it happens frequently at that particular time, but most certainly fatigue plays a role. One thing that we do in our program, and I recommend people do whenever they're having concerns, or especially if they're noticing changes in the kinds of mistakes they're making, is to create a log and log them very reliably over the course of a 1-week period. And quite often when people do this, they start to discover patterns where they have certain alert times versus fatigue times. Start to notice that they're more prone to making mistakes at certain times of the day that might be related to either food or exercise or work or family expectations. And usually when people do this over the course of the week and then they come back into our program, about 60 to 80% of all the difficulties they identified, they came up with their own solution for. And then the remainder of the course is designed to help them with the remainder of those difficulties. So I think it would be a very worthwhile endeavor over the course of the week to just try and keep a log of what you're eating and when you're eating it and what sort of activities you're doing, and sort of see if there's a pattern of something else that might be directly related to that 3 o'clock time period. So, for example, if your weekends are much more relaxing and you find you don't have that same sudden mental break or difficulties at 3 p.m., then it may in fact be related to the activity levels within your work environment throughout the day.
Yeah, it's not. I put 3 p.m., but it's roughly between 3 and 4, and I find that the words just start to disappear on me. I tend to, and it's not all the time. Obviously, it's not all the time, but I find it very difficult because when it comes, when you're asking or mentioning that it's Monday and it's actually Friday, that's a problem.
Yeah. Especially if you see that it's a very consistent pattern for you, one of the best solutions to that is to try and structure your day so that during that anticipated time where you might not be at the top of your game, that's a time period where you're doing tasks that are not the least bit cognitively demanding.
I work solely in a medical office, the only person there, so that's quite difficult to do.
You can't put the phone on hold for an hour?
Pardon me? I can't put anything on hold. No. But I also it's been very difficult, and I really appreciate the other lady who was explaining about her difficulties at work, because I went back to work after 2 months in an environment that I wasn't used to. I wasn't used to the medical field, and a friend gave me a job, and I was much more fortunate, and they were much more, patient with me, because I had to ask questions over and over and over and over, and I would get it one day, and the next day it would be gone. And I'd go back, and it'd be like, oh, my God, where is it? It's gone. And I would have to write myself notes continuously to just continuously remind myself how to do this new job. And, it's come along. That was 6 months ago, and I find it a lot better. But patients in employers are thankful in my case.
Right. Well, I mean, and from what you're describing is you're demonstrating to everybody listening that when you put the effort and the time in, you can get there. So you're seeing the improvement. So it's not as though
a big
no
improvement.
Capable period. It's just a new way of doing things and having to put the time in to figure out what that way is.
Yeah.
Thank you. Thank you, Bernice.
Thank you.
You're welcome. We had a question from Corinne, but she had to leave. Her question was, and I just have to find it here, is what is the incidence of cancer-related brain fog, Dr. Palmer? Or is there an incidence?
That's a somewhat tricky question, because there's not a lot of research. The best place to look really would be to look at what the meta-analyses have found, and the particular one that was done in Australia, where they're gathering all of the research and trying to really look at general trends. That particular one suggested that the frequency of occurrence ranges between 0% and 80%. So what that is saying is that there's a whole bunch of research out there that says there's no such thing as cancer-related brain fog. In other words, in those studies, 0% of the people that they tested had cancer-related brain fog. But there are difficulties and flaws. A lot of those studies actually did not use the kinds of neuropsychological tests that will tap into these high-level functional changes. In fact, that's a general difficulty within this discipline altogether, is that a lot of the neuropsychological measures that are available are not tapping into the high-level functional changes that people are having. So frequently people are coming back after doing the tests with scores that are considered to be perfectly normal, even though them and everybody around them will say that there has been a change. The other end of that spectrum, where it was 80%, that's really research that's suggesting 80% of the people we tested did in fact have cognitive changes associated with their cancer. But again, there were some problems in some of that research. In particular, in one of them, it was a breast cancer study where they, part of the recruitment process, asked people if they've had breast cancer and they're suffering from cognitive changes to participate in the research. So there was very clearly a selection bias. So I don't really know what the answer is. My personal feeling is, with respect to cancer, probably somewhere around 60 to 70% of everyone will experience some sort of cognitive change, perhaps even higher. But my bigger belief and perspective on life, since I work in many different areas with respect to brain fog, is I feel that everybody will experience some type of brain fog at some point in their life, whether it's age-related brain fog, menopause-related brain fog, stress-related brain fog, cancer-related brain fog. We will all experience. So the tools and strategies that you learn to address it will probably help everybody at some point in their life.
She's good, isn't she?
I agree. She is good. Peter had a question, who you were speaking with before. He lives on the East Coast. Is there anywhere on the East Coast that you could advise that he could actually go and take these cancer-related brain fog sessions?
To my knowledge, not yet, Peter, but I have been in communication with some groups in Nova Scotia, and I will be coming out to Cape Breton to participate in a symposium in September, and I'm optimistic that we will be moving forward in terms of training some people in Nova Scotia at least, and I'm always looking for opportunities. So if you know of cancer centers or individuals who would be interested in taking this type of work on, I'd be prepared to train them and try and get the programs running. I would like to see the programs right across the country as soon as possible.
Excellent. Right now, just for everyone else's reference, where are the programs right now that are running?
They are running in Alberta.
Okay.
They are running in Manitoba. They are running in several centers in Ontario, and they are running in Quebec.
Excellent. People can find out more information about this on your website?
They sure can, or by contacting me through my website. I can always let them know where different programs are running.
Excellent. Nancy and Amy, who are on a line together, it looks like, had a question. Nancy and Amy, do you want to press star 1 to unmute your line?
Yeah, I guess you were kind of answering it just now, but it was really, I'm in New Brunswick, and I guess the oncologists that we've been dealing with here haven't really recognized chemo-related or cancer-related brain fog. You know, we've had those conversations with them, but it kind of gets dismissed a lot. Mm-hmm. So it's just what kind of reception oncologists have had just recognizing cancer-related brain fog. And have you been doing any work, I guess, across the country with healthcare professionals or anything?
I am trying to. I have found so far most receptive have been the various nurse associations, and they seem to have a lot of really good education days and ongoing education for oncology nursing staff. So as much as possible, I'm trying to participate in symposiums or present at education days or conferences.
How would you suggest, so the presentation that you just did now, how would you suggest that I get that information to healthcare professionals in New Brunswick? Like how would I,
take it the next step?
Yeah.
It's tricky, and we have sent mailers out to oncologists. We've tried a bunch of different routes, and it's tricky for the oncologists because it's very difficult for them the research isn't fully supporting that cancer-related brain fog exists. So first of all, it's not really their area. Secondly, there's no clear-cut evidence to support it. And then thirdly, which is probably the biggest point, is even if they do say, yes, it exists, yes, this might be what you have, they don't know who to refer you to because there is nobody to refer to help address it. So it's a very difficult position I think they find themselves in. Nonetheless, I think you're right. It's very important to create awareness and to really get oncologists and healthcare professionals working in cancer care to really understand that these are difficulties that people are having. It's really affecting their lives, and that there are possible solutions.
Do you have any success with presenting this to insurance companies?
I've not tried that. I haven't tried that yet.
It would be another, at least to make them aware of these types of issues.
Yeah, it's funny that you mentioned that because my postdoctoral research that this was a part of many years ago, that original grant was given to the Rotman Research Institute by an organization in the U.S. specifically because insurance company or the HMOs down there had a lot of concerns about what is cognitive rehabilitation and does it really work and help people, because they were refusing insurance claims and treatments for it. So the whole reason this whole area of research started in my life was because of insurance companies. But I have not yet gone back to insurance companies to see if this is something that they'd be willing to support.
The 8-week program that you have running across the country right now, besides yourself, what type of, like, who else runs those? Do you have, like, a host of professionals that you work with?
Generally speaking, when there's an area or a province that's interested, what we will do is train people within that province or that center to run the program. And the background of the people that we train can vary. It more depends on their personality, their experience doing some group work, their knowledge of cancer, and their ability to learn about the brain and how it functions.
And just one final thing. So how do cancer patients in those areas pay for that course, like that 8-week program? Do they pay for that out of pocket themselves, or is it paid through insurance companies, or is it paid for through cancer centers? Or
so far, all of the programs that we have running across the country are free to the people who participate because they are being run through cancer support centers or provincial bodies like Cancer Care Manitoba. So it's either the cancer center or the provincial body who paid for me to go out and train the people, and now they run the program as part of their regular programming that is funded by whichever the body was that originally funded the training.
Ding, 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 ding.
That was a great answer.
That was a really good answer. That starts the brain kind of going. That might be a good direction to move in.
And by all means, stay in touch with me because I'm more than happy to work with you to try and figure out, who in New Brunswick can we approach and should we approach and how do we approach them.
I'll send you an email. My name's Nancy Baker.
Okay, that part I do have experience. I've made a lot of these approaches, not always with success, but I'm more than happy to help with that.
We're a tough nut to crack, let me tell you.
Yeah, let me tell you. Those eastern provinces are causing me grief.
Thanks, Nancy.
Thank you.
We are almost at the end of our time. We've gone a bit over, but there are 3 more questions. Sandra M. I think that Dr. Palmer just sort of answered your question right there. Did that answer what you wanted to ask? You were asking about her program, how long it goes on, and where it's available. Okay, I'm going to take that as a yes. Barbara, it's *1 to unmute your line if you still want to ask Dr. Palmer the question you had. Barbara C.
Oh, hi there. I was just wondering if you collect outcome data from your program and whether you have any long-term outcome data that speaks to whether participants are still benefiting from the program, say, a year later or 2 years out.
Right. That's a great question, and we are actually, the outcome data with our cancer groups we don't have yet. We're actually just in the final stages of collecting our last few subjects for what has been a multi-province research project testing the validity and the effectiveness of the program. So we tested people before the program and again after the program on a small neuropsychological battery, and we compared them to 2 control groups, a natural history control group, individuals who had signed up for the program, but they're on a wait list. So there is interest and they express the same sort of cognitive concerns, but they aren't yet receiving the program. And then we also are comparing them to people who are participating in a similar 8-week program that is not cognitive-based, so it's Tai Chi instead. So we're just collecting the last bit of data on that with the hopes of being able to analyze that over the summer and publish that or somehow share that information. We don't have any immediate plans to do the long-term follow-up, but we do have a series of published papers in our seniors work, which is virtually the same program, and those were 5 papers. And in that particular series of papers, we did have long-term follow-up. And what we did find is that immediately following the program, we did see big improvements in psychological well-being and task management, but very little immediate improvement in the memory tasks. But at 6-month follow-up, there is a sharp improvement in memory. So we believe that there's a consolidation effect that takes place with some of the memory techniques that we teach, and you don't actually start to see the benefits of them until several months after the program has ended. And at that 6-month follow-up, some of the task management and psychological well-being scores had gone down a little bit from their highest level, but certainly not back to the original levels.
Great. Thank you.
Thank you. Maureen P., you had a question. Please press star 1 to unmute your line.
Hi, it's Maureen. Hi, Heather. Hi. We know each other. I'm the voc rehab counselor at the BC Cancer Agency.
I know.
It's not for us not wanting to have you here, for sure. We really would like to get your program. But I think the challenge around the work stuff is the documentation to, like, basically the expectation from insurance companies and, in fact, employers is they expect verification of this. And, right. And you kind of mentioned yourself the neuropsychological data may even be underestimating it.
Right.
So I'm often a little concerned about even recommending or pushing a neuropsychologist to an insurance company to pay for neuropsych assessments because I'm concerned.
Neither. I don't think that you're going to get the results that are going to show quite clearly the deficits the person is having.
So by law, there's a catch-22 for people that are at work because if somebody medical or a specialist is not verifying the disability, the employer doesn't have to accommodate.
Yeah.
It's a real problem.
I was really hoping you would pipe in when that question because I know you have more experience in terms of the educational piece of it.
Well, ironically enough, the catch-22 is we do have a psychiatrist at the cancer agency who's kind of trying to take this on as an interest and kind of is sort of, I guess to some degree, sort of advocating, like at least ruling out the psychological component to it and kind of is sending sort of letters. And I remember once actually talking to Larry Bernstein, who's a neuropsychologist, and saying, what do you do? Same sort of issue for people that there's no documentation out there that people can give to their employers. And I remember Larry saying is if I'm really stuck and it's really obvious, we do sort of forward back to the psychiatrist to make the argument.
Right.
But it's a catch-22. It's really a bad situation for people.
It's a horrible situation, and it's not actually, unless the rulings change, it's not something that I see changing in the foreseeable future because, again, the neuropsychological measures, the valid and reliable standardized neuropsychological measures that are available are not quite tapping into the kinds of difficulties these groups are having. Yeah. And so I often advise people against getting the neuropsychological testing done because I think that can sometimes hurt their case. If the insurance company pays for that and they have the right to the results, and the results are saying that this person is perfectly performing normally within average range for their expected levels, I can't see that helping their case in any way.
Yeah, but it's such an awkward situation because without the employers having somebody medically, and again, the catch-22 is the neuropsychology assessments don't tell the medical staff that there's a neurological or a neurocognitive problem or don't verify it. The doctors don't have the expertise to kind of comment on it. And without commenting on it medically or through neuropsychology, employers don't have to accommodate.
Right. And I think the route that you're going, psychiatry, having a psychiatrist on board, and I believe maybe the person you're speaking about has contacted me to learn some more about the work that I've been doing specifically.
I think she has.
And I think that's the best route because I think they are the only healthcare professional currently in the position who can provide some sort of medical support. Because the neuropsychologist has to rely on their measures, and the measures aren't going to support it necessarily.
Yeah, it's a tough one.
It is a tough
Thanks,
one.
Heather.
Thank you for piping in, Maureen. I saw that your name was on the list, and I was really hoping you would.
Oh, no worries.
Thanks, Maureen. We have one last question. Dottie, if you want to go ahead and ask your question, it's star 1 to unmute your line if you're muted.
Yes, I think Maureen just answered my question. That's exactly what I was going to ask you, so that's perfect. Thank you very much. It was wonderful listening to you.
Thank you.
Thank you so much. Thank you, everyone, for joining us. Dr. Palmer, thank you so much for your time and for answering these questions so in depth. I know I learned a ton tonight. For everyone listening, and on your screen, if you can't see it, if you go to MaximumCapacity.org, you'll find out more information about the program that Dr. Palmer and her colleagues offer, and you can also contact her through that website.